Good evening, everyone. Welcome to the last session of the program. And the topic of discussion is very, very important and relevant, and that is disclosure of medical error. I think this is one gray area which we all deal with, but we really do not know exactly how to go about handling it. So I hope today's discussion will empower us with some deeper understanding of what is the need of the hour, what are the existing practices, what are the hesitations or barrier in practicing disclosure of medical error, and then how it is beneficial or useful to actually practice it. And of course it takes a lot of courage to uh, implement it in real true sense. Before I go further, I want to ask, yes, Dr. Praveen.
I interrupt for a minute?
Sure.
Before going for this topic, I just wanted to know from all of you, because I have been trying in my hospital for a long time, reporting of the medical errors,
Mhm.
despite convincing everyone that there is no punishment for this, it is only for the improvement or correction. But the reporting of the error is really very dismally low.
Mm.
So, what is your experience and how do you handle it?
I would have definitely brought in, during the discussion, but if you have started with that, that's also perfectly all right. I think once you will understand the reasons or the hesitation in disclosing, you will understand the root cause of dismal, reporting, and how to create a culture where it's called just culture, where people not only assume that they will not be punished, but they are assured and also they are demonstrated that they are not targeted or they are. It's a huge change in the culture. But I think once you start implementing and you start demonstrating that actually the person who reports is not only not punished, but in certain hospitals, they have started rewarding the person who comes and report. And also they are, encouraging that whichever department, brings up maximum number of reports on errors or patient safety compromise, they are rewarded for being the best department to come up with. So there are so many ways to actually, but I want others also to share their experience. But before that, I want to see what kind of errors have you noticed in your system, and then maybe we can take Dr. Praveen's question. So what kind of common errors have you noticed in various places where you have worked or where you have seen?
The
Yes, Dr.
commonest ones are the medication errors
Medication
at
error.
at every level, prescription level, the dispensing level, and reconciliation level. Everywhere, the medical errors are the most common errors that are,
Absolutely. I
that
think
we are
most of the studies have shown that 40 to 50% of the errors are around medication error. I completely agree. Yes,
Uh,
Dr. Nitin, I think you wanted to add something.
Yeah, madam, I think transcription and prescription errors have been the biggest format of
Mm,
this. But sometimes what happens is I think this is called as what Dr. Praveen is trying to put forward is this is called as CQIs. And these are something that we are trying to inculcate in the hospitals. But it looks as if people feel that no, if I raise a CQI,
mm,
it's going to be against me.
mm.
We come to a second phase where unfortunately in my unit now it's become like you raising a CQI against me, I'm raising a CQI against you.
Oh,
So it's coming to be now an interdepartmental thing
yeah.
where it's very important that a person in the evolution of CQIs, when we were working overseas, it was very clear that they are anonymized so that
Mm,
people are not aware that who has raised the CQI and who is it raised by.
mm,
Second thing is that there is a person who is a very senior person who is going to be making sure that nonsense CQIs are not raised. It doesn't look like as if it's going to be a bias between the two units. And there is a certain what I call gradations of those CQIs which are there.
mm,
And according to those gradations of the CQIs, I think if the way of handling the CQI is done, probably it gives you a better outcome. Like, for example, if that CQI medical error of a drug would lead to anaphylactic reaction and death,
mm,
then it would be then going into something called as a central event, which as per an accreditation system would get discussed by everybody. But over a period of time, there are a lot of other things that go below the carpet and slide down below the carpet, which are not brought to the light. And as you rightly said, it's very important for oiling of the system that these CQIs are raised, they're tackled with, and they're encouraged so that these errors are not, hidden, and they do not lead to a disaster in the future.
Absolutely.
In principle, all of us agree with what Dr. Mehul has said. But how do you actually do it? Anonymize? Do you keep a box where someone draws that error form?
Sir, in the unit where I work, we have a portal. There is a portal. You
They
have
can
to
trace then, no? Who has reported that?
Sorry?
On a portal, if you mail someone or something like that or send it.
So no, sir. I mean, it's a hospital portal. You click in, and
Okay.
you have a tab of CQI, and you just click on it. It doesn't capture your any details of yours. But it is left open to you, sir. Whether you want to leave your details. So that's fine. It asks you, do you want to sign off with your employee ID? And a lot of people have not done it, and it's got raised. The whole point being that it needs to be that confidence needs to be given to people. And I think the way of encouraging a lot of these things, as you asked, is we put forward examples. We put forward the RCA of that problem, that is root cause analysis of that problem. We put forward the solution. We put forward the the impact. So we've come to a level where we used to have at least 1 or 2 to 3 CQIs raised every day, and now we're showing this graph over a period of 6-8 months where they have started coming down. So we've also been able to control the nonsensical CQIs. B, we've also made sure that the number of CQIs are coming down, trying to enforce it to people that look, it is a healthy process. It is a process which is helping you out in improving things. And there is a bulletin that comes out at the end of the month or at the end of a quarter. You all can do it that way. And that's what we do, is we try and put forward in that bulletin the impact of that CQI. So whoever reads it feels encouraged that no, this was brought about, this was brought to the notice, this is what was done, this is the root cause analysis, this is the answer of it. And that's how people get confidence in the system.
So what I understand from what you are saying is that, like sort of a medical audit committee, there is some sort of a error reporting committee who analyzes, and then after that the message is given to all concerned.
Yes. So there are five levels, because every CQI, like in a day, as I told you, if there are 2-3 CQIs in a month, there'll be 90 CQIs. And any senior cannot do it. So there is obviously a quality team. So the quality team then divides it into 5 different varieties. And the topmost variety, which is central, and the near misses, are then segregated and then divided departmental wise. And every month there is a departmental meeting of that department where one person of the quality team is already there, who then brings up this CQI. But that person of the quality team has already done an RCA, that is a root cause analysis, found out the problem, spoken to the other department, found out a solution, and come with 2 options of the solution for that department and the other department to mutually agree on. And then it is closed. And that is then brought forward to the other public to explain them that this is the process of the CQI, and this is the way it is going to help the oiling of the system to make it run more efficiently.
So I think even if you don't have that portal system that Dr. Mehul has, you can have that anonymous, letter or box where anybody can put their, concern without signing it, and let the most reliable person in the system open the box so that it remains anonymous, and also there is objectivity and there is no blame game or targeting. And I think implementation can be done like Dr. Mehul has explained, that if you have quality team with you who are ready to work on the problem rather than working on the person, and then everything can be simplified and implemented. Thank you for sharing your experience, Dr. Mehul. Anybody else who would like to share their experience? How are you handling errors? And like, how are you addressing your employees' concerns or the patient's concerns? If anybody would like to share your systems functioning, how you do it.
Hi. So I am doing the audits in PMJY, Pradhan Mantri Jan Arogya Yojana, and I see a lot of claims and a lot of documents, uh,
Mm,
right from their pre-auth to prescription. I have seen many errors. Some errors are genuine errors, and
mm,
some since I am uh, based out of the National Anti-Fraud Unit, so my perspective is little different.
mm,
So I also see there are some errors which are intentional, and
mm,
so in that perspective, I
mm,
do check. And in case anyone who wants any kind of consulting, then I am there for their audits, prescription audits. You can definitely ring me up. I can provide you services. Thank you.
So I think, and now I want to ask others. I'm going back to my previous question. What kind of errors normally do you see? Like Dr. Praveen said, most of the errors are around medication error. So what kind of errors have you seen in your system or around you where you saw, some kind of error happened either in nursing care or in medical care or in whatever way, or surgical error? If anybody wants to share your experience.
Some of the
Report
errors that
error,
we've sorry, please go ahead.
Yeah.
report errors maximum it comes,
People don't report it.
especially PTINR.
Okay.
It's whenever we go for pre checkup of
Mm,
this one before going OT.
mm,
So there we got PTINR maximum
mm,
error. They arise from PTINR
mm,
because the machine they are using, the reagent they are using, we found many errors on that. So what we do, we find out a solution because we have 3 units, okay,
mm,
and
mm,
3 type of machines are used in 3 of the units. So
mm,
what we do, we collect the sample in 3 vials at the same time, and we send, especially whom we, I mean, like already they are having certain history.
mm,
So we do, especially for those patients, we send the samples to the 2 other units also, including our units, so that comes a cross check, so that there should be an error free
mm,
there,
mm,
because we many times we got this type of errors maximum before OT, where patient shift to OT, this
mm,
error comes maximum.
mm,
That is one. And another one which we got a big error in ICU, ma'am, while ventilation. We
mhm,
ventilated the patient, and our technician who was there in ICU technician uh, forgot to change the mode, ma'am.
mm,
Suddenly, I mean, like 5 minutes over, and
mm,
our intensivist saw that thing, and
mm,
he shouted like anything. And we was, I mean, it was ICU, but मतलब thank God कि patient attender तो था नहीं, we were saved in that case,
mm,
but it was a big error. मोड चेंज नहीं हुआ था बिल्कुल,
mm.
एंड उन इंटूबेट तो कर दिए, पर मोड जो चेंज करना था वो ही नहीं किए थे. It
Okay.
was a big
Now
error.
I want to take you to the next level.
In reporting error,
How
one thing
many?
is that we once
How
reported
many?
it to another
We
patient.
we are still stuck on reporting. I'm coming to the next level. How many of you disclose the error to the patient?
Report error, we disclosed. Yeah, ma'am. 100% I disclosed.
Regularly? You talk to the patient directly?
No.
Hmm.
Yeah, and a patient attender.
Patient
Not
attender.
patient
Patient
attender.
attender.
Yeah,
Okay.
but थोड़ा diplomatic way. We disclose, but very diplomatic way, ma'am. Bluntly, we cannot say that.
Okay. Who else rose their hand? Dr. Mehul and then Dr. Jayapriya. So, Dr. Jayapriya, I want to ask you, can you share any experience where some error happened either by you or by your team member, and you had to report because, I mean, I don't know if you did it voluntarily or it was something that couldn't be avoided. So you had to report. If you share your experience, it will be nice. Yeah.
See, a couple of things that happened in the operation theater that I can say, because when there is a mistake, mistakes happen during surgery, intraoperative events happen, not knowingly by mistake, or many times in laparoscopy, what we see is something, and we misidentify structures, and then we have to rectify it. For example, bile duct injury is a very common a complication in laparoscopic cholecystectomy. There's one of the very commonly performed surgeries for gallbladder stones. So many times it is an identification error, the visual thing, because we see in 2D and we operate in 3D. So I had transected a bile duct thinking it's cystic duct. And at that point, it was maybe some 7-8 years ago, I was junior consultant, and it's my consultant's patient, not my patient. So during surgery, we cut it across. Then now what to do? Next step is to open up and then stitch it back. We do a biliary bypass. So that has happened. Another error that happened is I was doing adhesiolysis. The uterus was stuck to the anti-abdominal wall, completely stuck. So I was alone. The chief was not there on leave. Nobody else to support. I was alone. I was dissecting it. It's very dense. And then what happened is inadvertently entered the endometrium. I've been cutting across the uterus. I didn't know. I've been buzzing. It's bleeding. Some clips and this. Finally, when I realized it is inside the uterus. One more complication that happened is in laparoscopy, we created carbon dioxide in the we fill the space. So the first step is to either create it by using a blind technique called Veris needle technique, where you put a needle and then insufflate. So this patient had some congenital abnormality where the liver was pushed down into the abdomen, all the intestines, and this is right diaphragmatic hernia. So I had to start the case. There was a debate between my boss and me that he wants to do open and I want to do lap. I want to try everything lap. So that kind of a situation. Then he said, okay, go ahead, start, put the laparoscope inside, let us see. So he was scrubbing up and I'm putting the Veris supraumbilical, usual where we put. So first time I connected, the pressure was high in the insufflator. And then I thought, what's wrong? So I said, stop. I removed the needle, put it back. We usually aspirate to check. When I aspirate, it is blood. Okay. So, and the next moment, patient arrested. That's all we know. So first Veris, pressure is high, removed. Second time, aspirate blood, patient arrest. Anesthetist, we have fantastic anesthetist, and he says carbon dioxide, this is air embolism. This is embolism, and then quickly, I started resuscitating and arrested and cardiac massage. We got the cardiac OT is right next to our OT. We called in the cardiac anesthetist, revived the patient, and then nobody knows what happened, including me. I don't know what happened. I put a Veris in the usual place where we put, and then I aspirate blood, so I don't know where my needle is. My boss just scrubbed wearing his glove. Patient arrested. Once they revived, he thought maybe it is in the IVC or aorta, we don't know. We just opened up and saw there's a liver. I had liver sitting in the umbilical region. I had punctured the liver. So first time when I connected, the pressure is high. So I knew I was not in the right plane. I removed, I punctured, I aspirated. Possibly the needle was somewhere into some vein, one of the hepatic vein tributaries maybe. And I connected, the air has gone. Whatever little air has gone. And this is what happened. Later we came to know that, the tubing had air. Usually we insufflate carbon dioxide. So the tube has air. So the first, whatever comes out from the machine, that part is only air. So I've inserted air into the liver and has gone to the IVC and to the heart and pulmonary embolism. So these three situations where I personally committed. So this first situation where of course, the last one I described, this a young gentleman, 24-year-old with diaphragmatic hernia. So I revived and all, then we decided not to proceed, shifted to ICU. And then we just closed and came. We didn't proceed. So I was so upset. So upset. And we had to talk to the attenders. My chief was there and then he called. See, these are situations, he says, you have to be very, very honest. So he called and said, Humne galat. This patient was from Bangladesh or some, northeastern. So he says, galat. kiya humne. We put into the wrong place, but it's also because the patient had some congenital thing. It was a mistake. And now the patient developed a cardiac issue because of that. And then we not proceeded with the surgery. And then luckily, this patient attenders are very, very nice people. They agreed. And I think 1 week, 10 days, and then we discharged him. And I remember they come for follow-up, but I don't remember that we operated later. This is one thing, but the patient attenders could understand and things like that. The one where I cut the bile duct, again, we can't just proceed. No? So you go out, de-scrub, go out, talk to the patient's attenders and say, this is what happened. Humne galat cut diya. So, and then we have to do corrective measures. There's one instance where I entered the endometrial cavity. What I did is we sutured it back. I sutured the uterus. I called in a gynecologist doctor, but he couldn't do lap. But he directed me what to do, corrective measure. We finished the corrective measure. I went out and it said that, while I was doing, I misidentified. And I entered the cavity and I've stitched it for now. So we need to postpone period for the next few months by giving some medications so that the patient doesn't develop endometriosis. So there's no other choice that you have to go and face it. If you face it on the same time, same day, and to be very, very honest, is what happened and we are sorry, they understand. There are situations, I remember one more situation where we did a gallbladder surgery, same lap chole. The gallbladder was so shrunken, thimble gallbladder. Dissection, there's another surgeon, senior surgeon operating and me assisting. And then we went, finally we couldn't reach. And we decided that even open would be difficult. So we kind of deferred. The surgery was deferred, a drain was left, and that's all. And the surgeon was there, it is his patient.
I ask you here, Jayapriya, like all the time when you shared this, your patients, attendants accepted what you said? Nobody kind of questioned your competency or your...
See, this patient with whom I had a problem with the uterus, they didn't come back to me later. I referred them to the gynecologist for medications and I asked them to follow up. I think first follow up for suture removal, they had come and then they didn't come back to me. They probably would have gone to another surgery. Yeah. So this...
I'm glad that you have so many instances to share where you...
No, there's one more instance I wish to say because the last one I was sharing. The surgeon went and said surgery ho gaya. The surgery is over and then patient is fine and he walked back. He never disclosed that he did not remove the gallbladder. I was assisting him. And then what happened, that same night, I got a call from the hospital and they said the patient wants to talk to you. And the patient asks me, what happened to the gallbladder? How many stones were there and things like that. Then what am I supposed to do? Because I was witnessing the whole scene where this chief senior doctor is telling, he's not mentioning anything about not removing the gallbladder. He should have said it was a difficult surgery and hence we couldn't remove. But he didn't say it. I'm a mute spectator there, but he's a chief. I know there are some chiefs who allow us to talk and, some chiefs we face dire consequences. But here and then what I did, I think that night I was on call, so I got to meet the patient. And I said, see, there was some difficulty and then we didn't, for your safety, we did not remove the gallbladder. And that became a huge issue. They raised it to the management, to the DMS and everything. The senior consultant had to cut a sorry figure. And that is when I understood maybe I should have asked him straight. I could have. There's another instance. I was working another hospital outside Chennai and there they did a wrong surgery. Wrong. Absolutely. The indication was wrong. They went ahead and operated. And the senior consultant called another senior consultant to come to theater. See, I told him, and I'm looking at the CT, sir, this is an inoperable tumor. And no, chup, keep quiet. And I'm trying to discuss in rounds. No, you keep quiet. And I have enough evidence as a junior doctor to say that you can't operate. So, yeah, so this this is a chronic pancreatitis case. So I was in the theater. He's opening up a head of pancreas mass, inoperable. And he's telling the patient that it is chronic pancreatitis because the duct is enlarged. And then I am supposed to assist. And I'm a trainee. And it's a new place. It's a far off place, and I'm assisting. And I was so upset. So I'm not talking. I'm just standing there. You know what he does? Says, JP, come. I joined that unit 1 month. It's just 1 month. He says, JP, come. You are doing a lateral pancreatitis. Within 1 month, it's a major surgery. Nobody will allow anybody to do. So he kind of pacified me by allowing me to operate. So I did the LPJ for that patient. And what happened is affected me a lot. He's assisting, he's saying, fantastic, you have very good hands, appreciation for the surgery. Later I understood he's kind of brought me into his crime. So then I left that institution. I went to the higher up, I went to the CEO and I said, see, I can't work in a situation like this. And the other surgeons are hand in glove. So one surgeon will say, another surgeon will come for on-table second opinion and he will write his notes. And go. So he kind of validates his wrongdoing by this. So I've been in such very, very difficult situations. So this institution had to leave. I informed the highest person in the hospital. They noted down, they recorded my thing, but they didn't do anything about it.
Nothing must have changed after you left, I'm sure.
So, yeah.
Thank you. I think, Jayapra, you have shared your lot of experience for all of us to actually reflect on. And I think most of us are facing or seeing something similar, but things are very difficult when you have to actually go and talk to the patient party. I'm glad whatever experience you shared, every time you spoke to the patient very honestly and the patient accepted it. I'm not sure if all others also had this good fortune where the family did not blame you for the outcome or did not challenge your competency and your intention. Anybody who wants to share where you had you disclosed and the family became aggressive and blamed you for the outcome and also challenge your competency and your ability? I'm sure that's one of the concerns every person who has to disclose it. So I wanted to do a role play around it, but I think Jayapra has brought in lot of cases. Anybody who would like to try their hands at disclosure of medical error? Who would like to be somebody who's doing it on regular basis? I don't want that person to do it, but somebody who wants to really see how it is and how difficult it is, and if anybody wants to try their hands. Mariam, will you? No? Try. Why I'm saying this? Because I mean, there can be a chance where you have to do the talking. At least some experience, some exposure will help you to be mentally ready for it. Because see, like Jayapra is mentioning, Dr. Mehul, Dr. Praveen, so they're all very senior people. So I'm sure by now they have learned it by doing it on regular basis. Mariam, would you like to take or somebody who has to do it or is doing it?
Yeah, on regular basis, I don't need to do it. And I'm really scared.
Yeah, God forbid. I mean, sometimes I like we know sometimes even test dose can cause fatal outcomes. We have seen that happening. So, would you like to try your hands, Mariam?
Okay.
So I'll share the case, but I need two family members to be the attendant of the patient because we don't need the patient here. It's the attendant who needs to be doing the talking. Who would like to be the patient's attendant? I'll share the case. It's a real life case. Vedita, will you be? And who's the second one? Dr. Mehul? Okay.
I'm even scared now. Let's come in.
So it's a very safe place, we all can comfortably, talk to each other. So I'm just sharing the case with all of you, especially for Mariam to read. And if anyone has a question around the case, we can, discuss further and then we have the role play. So, okay, this is the case, and this is a true case, actually, real life case, which happened in Delhi. So this is the patient. By the way, who has joined with the name Dr. PM?
I think that is Dr. Priyanka.
Oh, okay. Yeah, maybe because she said she will be in the program. Never mind. So this is the case, Mariam, for you and for Dr. Mehul and Nivedita, because you have to act as patient's attendant.
Madam, this is a real life case?
Yes, this happened in Delhi,
Wow.
in one of the trauma centers of Delhi.
Right.
So,
See,
Mariam,
this sort of error occurs. They will forgotten about checklists and protocols
yes,
and everything. Yeah.
exactly, exactly. So,
Okay,
Mariam, once you have read the case, I will stop sharing the screen.
okay. Only broken leg, no right or left.
Oh,
Okay, ma'am.
okay. So now I think we all will switch off our videos, except three of you, and assume that Mariam, you have already operated the patient. Of course, when you were operating, you got to realize that this was not the case. There is some identification failure on the staff's or the residents' part, and you have to. And the family is in the know of it now. There's nothing that you can hide from them. They can see the patient's leg is you know.
Sutured and
Yeah, sutured and dressed up. So naturally, they have query that what it is. So let's see how you handle it. I'm also going to switch off my video. Okay, go ahead. So 5 minutes are okay? 3 to 5 minutes?
okay.
Okay.
Okay. Hello, good morning. I'm Dr. Maria. Uh,
Namaste.
are you the attendant of Dr. Mr. Rakesh?
हाँ जी, आप कौन है जी मैडम?
Is Mr. Rakesh your attendant? जी, I'm Dr. Maria.
आपने ही
मैं डॉक्टर
ऑपरेशन किया
मरियम
था?
हूँ। आप अ, जी, मैं पहले आप राकेश के अटेंडेंट हैं?
जी हाँ।
जी हाँ, क्या बोलना है बोलिए तो सही। पहले पहले बताइए क्या बोलना चाह रहे हो
हाँ,
आप।
ओके जी। आई एम सो सॉरी टू इन्फॉर्म यू दैट हम लाइक हमसे थोड़ा गलती हो गई। हमसे
गलती?
गलती हो गई कि जी हाँ, अ,
गलती? क्या
वो
गलती?
और एक कोई
बोलिए।
पेशेंट थे, और एक पेशेंट थे।
जी।
वो हम राकेश को वो पेशेंट समझ बैठे। जब हम ऑपरेशन के लिए उनको पोस्ट किए, उसके बाद उनको खोलने के बाद पता चला कि ये वो पेशेंट नहीं है जिसका लेग सर्जरी करना
मैडम,
था।
आप तो इतना
तो
कैजुअली बोल रहे हो। इतना कैजुअली कैसे बोल सकते हो इतना बड़ा ब्लंडर करके? कैसे बोल रहे हो आप ये बात? यू हैव डन ए ब्लंडर मैम।
जी हाँ,
आप
या
हॉस्पिटल में
इट इज
बैठ के
वेरी,
आराम से ब्लंडर कर रहे हो। ऐसे कैसे बोल
यस
रहे हो?
इट,
मैडम आपको हम
जी
कोर्ट में लेके जाएंगे।
हाँ,
हम आपको
ऐसे
कोर्ट में लेके
आप
जाएंगे।
आराम से बोल रहे हो भाई, आराम से बोल रहे हो।
आप
हमने
मेरी
गलती
पूरी
कर
बात
दी
तो
है
सुन लीजिए।
आपकी डिग्री तो चली जानी चाहिए मैडम।
बिल्कुल।
जी,
आप कैसे बोल रहे हो? आराम से
आप
बोल रहे हो
मेरी
कि
बात तो सुन
ऐसे?
लीजिए पहले।
नहीं, आप
ठीक है,
आराम से
आप,
कैसे बोल रहे हो? हाँ, वो हमारे पेशेंट है मैम।
जी मैं समझ
एक बार
नहीं, आप
सकती
सोचो
स्माइल
हूँ।
भी कर रही है
सोचो।
मैडम। आप
हाँ, वही
आपको
मैं वही
आपको तो
सोच रही हूँ।
कोई
आप तो
नो,
कैजुअल में बोल रहे हो, कैजुअली बोल रहे हो। मतलब आपको कोई मतलब ही नहीं है, कोई भी कुछ भी हो जाए।
दूसरे कोई होते थे तो ये हॉस्पिटल तोड़ डालते थे
हाँ,
अब तक।
आप कैसे,
जी ये
मतलब
गलती,
सोचो जरा। ये
हाँ
गलती
मैं
के।
समझ सकती हूँ, ये आपके लिए बहुत
तो
तकलीफदेह बात
मैडम,
है।
आपको तो वैसे स्टाफ रखना चाहिए ना। आपके पास कुछ तो होना चाहिए। तो मैं मतलब कोई भी आ जाए, एक्सीडेंट और भी पेशेंट आ जाए तो किसी ना किसी को उठा के कुछ भी कर दोगे? अरे वाह, सही है। ऐसे थोड़ी होता है। इतने बड़े हॉस्पिटल खोल के रखे हो और ऐसे पेशेंट को करोगे? ऐसे
जी
नहीं
आपका
होता मैम।
गुस्सा, हाँ जी आपका गुस्सा वाजिब है। लेकिन सब लोग ह्यूमन है एट द एंड ऑफ द डे, राइट?
मैडम, वो
सबसे
भी तो
गलती
ह्यूमन
होता
है।
है।
जिसको किए हो,
जी
जिसका गलती
हाँ,
हुआ है, वो ह्यूमन ही है मैम।
आपने किडनी नहीं निकाली, वो कैसे
जी
हम गारंटी ले?
जी, आई एम
आपने किडनी नहीं
सॉरी।
निकाली, उसके कैसे गारंटी ले? हाउ डू वी ट्रस्ट यू मैडम? हाउ डू वी नो व्हाट अदर ऑर्गन्स हैव बीन हैंडल्ड?
You can trust me because I'm coming here and telling you what you've done wrong. I can understand it is very painful for you as an attendant, but this is
If you
what
were the
happened,
patient,
and
how
I'm
would you
so
feel it
sorry.
madam?
And Yeah, I would also feel like how
Madam, we
you're
are
feeling.
giving you money. It's not free of cost treatment, ma'am. It's not absolutely free of
Yes.
cost treatment. We are paying for that. So when we are paying, we want the result. And this is the result. You are saying you have done a blunder. It's not a mistake, ma'am. You have done a blunder.
Yes, I understand it was our mistake. I accept it.
I don't think so. This is appropriate, madam. I don't think so. You are fit to be a doctor. I think your degrees are questionable. I'm so sorry, madam. Your degrees are questionable. This is an act of omission and commission, and I think this
Do
needs to be taken up by the court of law also.
Okay. Okay. Do you want to talk to anyone senior to me
What to say?
about
What they
it?
will say you the same thing that you are saying. करके क्या फायदा, मैम? आपका वर्ड और उनके वर्ड में क्या फर्क रहेगा? कोई फर्क नहीं रहेगा. वही सॉरी एंड सॉरी. तो सॉरी ऑलरेडी कर चुके हो, मैम. और क्या करना? बताओ.
I think it's like I'm feeling very difficult to be in this position for this long.
Sorry, Mariam, to have put you in that position. Vedita wouldn't have let you say anything.
मैडम, I face like anything. 2:30 को हॉस्पिटल जाना
My
पड़ता है,
hands
मैडम.
are like feeling so cold.
मेरे को 2:30 ना कभी कभी जाना पड़ता है. 2:30 मिडनाइट को भी जाना पड़ा लास्ट आने के पहले. एंड आई केम बैक एट 4:30.
कैसे मैनेज करते हो निवेदिता फिर?
मैडम मत बोलिए मैडम. आफ्टर काउंसलिंग, कंटिन्यूअस काउंसलिंग, डेली काउंसलिंग, एंड दैट इज आल्सो ट्वाइस काउंसलिंग.
चलो निवेदिता, अब रोल रिवर्सल करते हैं. निवेदिता अटेंड करेगी एज अ पेशेंट, एज अ ट्रीटिंग डॉक्टर, और मरियम और डॉक्टर मेहुल जो है करने. ठीक है निवेदिता? लेट्स सी हाउ यू हैंडल, because there's a lot to learn from. I think before we go to that, I want to ask Mariam, uh, how did it feel being there, Mariam? Unmute your
You're on
device.
mute.
Mariam, unmute karo. हाँ.
I was feeling very nervous and
What
like
was the concern?
it was very difficult to control myself. I was not getting words to talk.
You were not getting. And what were your concerns? If it was a real life case, what would have been your concern? If you were actually handling it?
Yes, when they said that like my degree has to be like my license has to be cancelled or something like that, I was feeling that pressure. What after that if that really happens?
Very true. Very true. What do you think? What kind of skills would have helped you handle this situation? Of course, you were trying your best, but what skills would have helped you to handle this situation effectively?
I think how to control myself, like
Mhm.
uh,
You were much
like
in
I
control. You were not fighting back or arguing or not even.
yes, but my emotions, like I was feeling nervous and I could not control that.
Mhm.
I
But
was
you were
feeling
smiling.
nervous.
You were smiling. I don't know if you
Yeah,
were
I
really
didn't realize
smiling,
that I was smiling after he
and probably
like
that
I was
also. Yeah,
yes,
attendant. How can you smile
that
in
is
such a serious situation?
yeah, I didn't realize till he pointed out,
Yeah.
because usually I smile, but
Mm.
like it was
That's
like it
actually.
is
Yeah,
actually role play is very difficult for me to play.
I know. But then these situations are, we handle such situations day in, day out. So that means sometimes we are not even in know of what my facial expressions are. And that itself
Yeah.
could upset the other person, that you don't seem to be serious about it. You don't seem to be affected by my state of affairs. So that can be, that can be very, but what do you think you did effectively, Mariam?
I think I kept calm
Okay.
and I the thing that I said, he told me. Dr. Mehul said me why you should. So I think I replied it
You
okay. So
apologized. I saw you apologizing. I also saw
yeah,
you saying that, yes, I understand. If I were in your position, even I would have felt the same. I mean, you were
yeah,
empathizing, you were expressing empathy, and you said, yes, I accept that it's a very big mistake that has happened and you never disowned or you didn't blame your staff that it is not me, it is my staff who did it. And they are the one who should be blamed. I think you did that very well. I want to ask now the attendants, what do you think Mariam did effectively?
Well, she did keep calm.
Mm.
She did acknowledge her mistake. She was very open about it. She was clear about the fact that the event has happened and she took the full responsibility for it.
Mm.
But I mean, it would have been, I think ultimately, whenever there is a disclosure of these uh, problems or events, there needs to be some amount of background being raised. There needs to be a team of people to go along with. You can be the sole person to talk with, but you need to have a team of people with you.
Mm.
You also need to be building up the situation and explaining them.
Mm.
And yes, you should own up and say that this has been a mistake.
Mm.
This is something which is never happened before, would never happen before. You need
Mm.
to tell them that this was the problem. This is the root cause. These are the corrective actions we've taken, so it never happens again, never gets repeated again. And we are
Dr. Mehul, all that would have only happened later when the attendant would have calmed down. I think we were
sure.
still struggling to calm them down. If you
Yeah.
saw, I mean, still Nivedita was really very annoyed and very, aggressively talking to her and blaming her for the situation. I think Dr. Priyanka is here.
Good evening, everyone.
Good
I think
evening.
both of them are expert in being angry patient.
yes, I agree.
Nivedita
I
definitely.
wasn't angry. You marked
But
me. I wasn't
he's
angry.
like, yeah, of course, angry
I was
patient.
intimidating.
Yeah.
Yeah.
But you were scaring her by using difficult punishments for her. Yeah, that's true. Yeah. So I want to ask Nivedita and Dr. Mehul, how did it feel to be there in the patient's position?
You feel definitely cheated. You feel it's sad, and you obviously don't want that to happen again
Mm.
and to nobody else. And probably with the way that the present times are going on, definitely, madam, there would be a thought that would come across that there needs to be a appropriate compensation being done for this. So I this is the way a relative. This is the way I think a relative would uh, be coming up to me. So I
Mm.
need to be prepared for all of this when I
Mm.
go up.
Mm. Mm. Absolutely. So what is the observation of the Nivedita? Sorry, do you want to add something to what Dr. Mehul said?
One more thing as for patient, this one, see, एक हो जाता है ना कि we are now helpless.
Mm.
Nothing can be done.
Yeah.
I mean, उसमें सुधार नहीं सकते है ना, जो हो गया नुकसान हो गया सो हो गया. तो ये नुकसान का भरपाई मतलब पैसे से भी तो नहीं हो सकता ना मैडम. उनके साइकोलॉजी सोचो, पैसा से भी चाहे कितना भी करोड़
So
दे दो.
if you were operating and you operated and you removed the healthy kidney, you were supposed to remove a kidney
डैमेज वन. हाँ
damaged one,
मैडम,
and you
उस टाइम अगर हम बताएं, एक बात जरूर बोलना चाहिए, मतलब मैं जो बोलती हूँ मैं नॉर्मली कि देखिए बिल्कुल आप जो बोल रहे हो मुझे मैं एग्री करती हूँ, आपके जगह पे रहूंगी ना तो आई विल रिएक्ट इन दिस सेम वे. आई एम नॉट टेकिंग दिस एज अ ऑफेंसिव वे बिकॉज मुझे पता है आप उनके गार्जियन हो, आप उनके मम्मी पापा जो भी हो, मैं भी आपकी जगह पे रहूंगी ना, मैं भी ऐसे ही करूंगी. लेकिन आप इस सिचुएशन को देखो कि हमने इंटेंशनली किए नहीं. मतलब मैं जानती हूँ अपोजिट साइड से बोला जाएगा, इवन मैं ये भी बोलूंगी मुझे पता है आप इतने खर्च कर चुके हो, लेकिन देखिए हमने आपको बताया थे पहले, जो मतलब मेरा सिचुएशन जो मैं लास्ट सिचुएशन था, इट वाज 25 years गर्ल था और लाए एकदम आखिरी स्टेज पे ले आए थे। वो इंटुबेट हो गया था, इमरजेंसी में ही हमें इंटुबेशन करना पड़ा था। और उनके मतलब उनके चाचा जी, उनके पापा नहीं थे, 2 साल पहले एक्सपायर हो गए। तो साइकोलॉजी उनकी मम्मी का क्या होगा, ठीक है। उनके चाचा जी, उनके दादाजी को कंटिन्यूअसली वी वाज काउंसलिंग, यूर से ये स्टेटस, ये स्टेटस। फिर हमने एबीजी किए, उनका भी रिपोर्ट दिखाया कि देखिए ऐसा सही नहीं आ रहा है, सब कुछ दिखा है। उन्होंने क्या की गलती कि उन्होंने उन बच्चे के मम्मी और उनके मासी को नहीं बताया। एज ए रिजल्ट क्या हुआ, जब 2 बजे वी टोल्ड कि वी आर ट्राइंग, तब हम सीपीआर दे रहे थे, तो दे स्टार्टेड शाउटिंग और चेयर उठा के पटकने लगे। और मेरी जो फ्लोर मैनेजर था उसको भी एक चाटा मारा। तो तुरंत मुझे सिक्योरिटी ने फोन किया, मैडम कम इमीडिएटली। तो गाड़ी भेजे, मैं आ गई थी 2:30 बजे। देन मैंने ना, मैं विश्वास नहीं करोगे मैडम, मैं जाके ना उसकी जो मम्मी थी वो रो रही थी ना, मैं उसको जाके हक की कि मैं भी एक माँ हूँ, आप, मैं समझ रही हूँ आपकी बात करके। मैं हक करके मैं अपने केबिन पे ले गई, ताकि बाकी जो एनवायरमेंट हो ना, चाहे मतलब वो शांत हो जाएंगे, क्योंकि मम्मी को देख के तो ऑटोमेटिकली उन लोग भी चिल्लाएंगे। तो उनके मासी और माँ को लेके ऐसे हक करके ना, मैंने बोला मेरा भी ऐसे ही बच्चे हैं इस उम्र के, आप आओ मेरे साथ, मैं जानती हूँ मैं भी एक माँ हूँ, आपको कैसे लग रहा है करके। धीरे फिर मैंने पानी पिलाया उनको, वो चिल्लाने लगे, फिर भी मैंने पानी पिलाया सब कुछ। और मैंने एक बार भी नहीं बोला कि आपने मेरे स्टाफ के ऊपर हाथ क्यों उठाया, वो भी मैंने कुछ नहीं बोला। फिर मैंने बोला कि आपकी जो गार्जियन थी यहाँ पे, हमने उनको आवर्स टू आवर्स हमने उनको दिए। फिर मैं जो गार्जियन, जो चाचा जी थे, उनके दादाजी, उनको मैंने बुलाया और किसी को अलाउ नहीं किया मैंने केबिन पे। फिर मैंने बोला आप बताओ भाई, भाई साहब हमने आपको क्या बोला, हाँ मैडम आप तो बोलते ही है। तब वो उनके देवर को चिल्लाने लगे, आपने क्यों नहीं बताया हमें। तब उनके अंदर ये पता चल गया कि दे नोज एवरीथिंग, नाउ दे कैन नॉट शाउट ऑन मी। तो इसी तरीके से 4:30 देन आई केम बैक आफ्टर हैंड ओवरिंग द डेड बॉडी।
I think you have shared another good experience. Dr. Priyanka, I think you wish to say something. Go ahead. Yeah.
There should be clarity between medical negligence, like wrong site of surgery or leaving a mop inside, and a surgical complication. So, when there is a surgical complication, like last month, we had a totally rare, unexpected big aortic vessel injury during a laparoscopy. I was assisting my friend. So, because of the quick action, we were able to save. Aorta is the biggest vessel. Got injured, but we saved the life. And we really, the whole system got into action. But then this is a medical complication, like surgical complication. We explained, then we were, just keeping track. So till now, the patient has understood, and it's even the most responsible surgeon who was the admitting surgeon. Everybody is asking, how come your patient is convinced? How did you convince the attenders ki the pura aorta has got injured and major vessel injury, and she came for a small surgery and now she has a big cut. Now, after 1 month, they are telling we want plastic surgery. We want, so they are at this stage now. But we don't know if they complain. But even if they complain, this is a known complication. But if it's a medical negligence and then the attenders are angry, then it's a totally different situation. But when it's a surgical complication, again, make them sit down, tell them this is and that is why the consent form is so important, where even we sometimes need to take the risk of death also. So
we have to make a mention of it and tell that. Yeah. Thank you. Thank you. Yes, Dr. CEO, you wish to add something?
Uh, yes, ma'am. Just to, yeah. So now, if there is a negligence, needs to the doctor or the healthcare provider needs to understand the medical legal aspects behind that. Say Dr. Mehul was saying that we'll take it to the court. Now, in the court of law, there are
CEO, switch off your
there is
video.
criminal negligence. There is.
Please switch off your video and speak because, yeah, go ahead.
Yes, yeah. So there may be a civil negligence. There could be a criminal negligence now in the court of law. But but the communication that is being required in case if the patient party gets very angry and violent, then what we learned in our last sessions, we would try to put those steps into action. But at the same time, the doctor needs to be aware, or the healthcare provider needs to be aware of what are the types of negligence, first of all, and there are various doctrines related to negligence and how they can be faced, so that is my take. Yeah.
Sure. Thank you for bringing that up. So honestly, even very seasoned clinicians, find it very uncomfortable and difficult to communicate medical errors, because one, we are not given any practice or training, and plus we are never mentally ready, and there's a wishful thinking that nothing will go wrong at my hands, whereas it can happen with anybody. So I think there has to be some understanding of how do you really go about doing it. So we talked about attending or addressing patients complaints, and then resolving them and handling aggressive patient party. I think more or less the protocol is same of handling that aggressive reaction, but there are a couple of more points that I would like to share with you. But before we go further, I want to ask you to write in the chat box, what do you think are the major concerns of the clinician, when they have to disclose? So what is it that stops them from disclosing? What are their major concerns when it comes to disclosing? Write in the chat box.
Ma'am, is it a complication or negligence or
Error. It's an error. Even for complication, if you have not prepared them and if you have not talked about, and you didn't expect, naturally the family is not going to view it as a complication. For them, even that's part of error. Once we will discuss definition, I think we'll have more clarity on it. People see it as an error. Yeah. So there's guilt, there is fear, yes. Then image, yes, especially in front of patients and their own fellow professionals. Fear of name calling and bad name, reputation damage, yes. Legal litigation, yes. Nowadays the situation, yes, medical fraternity and everybody is facing that way. So hospital overall is also facing legal action, reputation, physical violence, absolutely. Fear of that, fear of threat, and also privileges that you lose from the hospital, absolutely. So I think there is a realization that yes, every clinician fears that there will be some retribution, there will be some litigation concern, maybe they'll have to financially compensate the patient, or even as Dr. Mehul was constantly saying that your license should be cancelled. And I mean, there are instances where the doctors have been, they have been suspended from the council, maybe temporarily or for longer period. So those are very common concerns that stops people from coming out with the yes, loss of hospital trust on the doctor, and they feel that, oh, you're not good enough. Absolutely, yes, Anas, I agree with you. So let us first understand what are the definitions, actual definitions, and what is patient's understanding of these situations. So let me share the screen with you and take you to the presentation. So if we talk about definition, I think medical errors, it's clearly failure to complete an action that's required, or use of a wrong plan to achieve an aim. So it may result in adverse outcome, it may not result, but then error is an error, whether it harms the patient or not. Whereas complication, as also discussed by some of you, is clearly an unsuspected medical condition that arise during the treatment of a patient in a hospital. That is documented. There is evidence that these complications can happen. But then again, when you communicate complications, I think concern is same, especially when you have not talked about this possible complication, or if it is a remotest complication, but then that happens in your case, then it becomes very difficult to explain why did that happen. And even like Dr. Jayapriya, when she was mentioning that we went and said that humse galti ho gaya, this whole sentence, I don't think it is very easy to come out with when you have to say कि ये गलती हुआ है या ये complication हुआ है patient के case में. Omission, we all know, when something is left undone or there's a neglect of duty, and at the same time, I think even unanticipated outcome will have aggressive reaction, because when you didn't expect something like this to happen, then definitely patient and the patient's family would blame us for the situation. Now, when we talk about the definition of error from the patient's point of view, it is very broad. So like we said, even complications or unanticipated outcome, they view it as error. So it's very broad, and it even includes something that is non-preventable, that is not in your control. They even bring in poor quality service or poor communication also as an error. Whereas I think our definition of error is very narrow, where we assume wherever there's a deviation from the accepted standard of care, then we consider this as an error. Now, coming to the expectation of disclosure, we all know that patients want to know everything, even including near misses, where the patient has not been harmed, but they want to know if something really went wrong in the patient care. Whereas we prefer only errors that cause significant harm. We want that to be communicated. Rest of the things we want to just not talk about. Now, how should the disclosure of an error happen? Patients would prefer truthfully, honestly, and having a complete information, but in a compassionate manner. Whereas physicians prefer to give minimum disclosure, whatever is required, and that also in a matter of fact manner, and making it more like, yes, that could have happened and this happens, not like taking responsibility. On the other side, when to have the conversation, I think patients want, or when I say patients, it's patients party I'm talking about. They want it immediately, as soon as possible. Whereas we sometimes avoid talking about it and we think, let us gain some time before we actually face the patient party and talk about it. We have seen a lot of time surgeries going wrong, patients being shifted to the ICU, and the family being informed about some error or something later on, maybe even after, say, 8 to 10 hours. And we want to really wait to have all the facts and all the information before we do it. Coming to apology, I think patient's expectation is that they expect us to apologize. Whereas we think if we will apologize, the responsibility will come on us, and also it can be a legal liability. Now, I want to ask you, what do patients expect? What do you think patients expect?
Truth. Only truth.
Truth and only truth. Write in the chat box, what else do you think patients expect when you talk to them about anything that has happened to the patient? It could be complication, it could be error. What do you think, what they expect? Write in the chat box. Honesty, truth, solution. Yes, honesty. Safety, honesty, good outcome. Yeah, good outcome. Yeah, even after something has gone wrong, whatever best can be done to correct the situation or minimize the damage. Early recovery. And if anything goes wrong, explain them. Okay. Honesty. My patient should be safe. I'm talking in the context of once the error has happened and once you're talking to them about error, what do they expect? So, of course, they want to make sure to make the patient safe and minimize the damage. Acceptance of error, yes. Financial support in case if it is causing financial burden to the patient and family, definitely they would want you to compensate for that. And then arrange corrective measures. Yeah, that's what they want to make sure that the patient gets best of care. Clear, honest, and safe. Okay. Compensation and revenge on the erring person. Yeah, at times they even ask, I want to know the person who has done it and I want that person to be punished for that. Compensation, yes, and corrective measures and help for extra stay, especially if they have to pay for that. So they really want that compensation and also not to pay for that. Yes, I think patients expect first of all that yes, please accept that this has happened. They want to have all the details of what exactly happened, and anywhere if we are not coming out in an honest manner, they assume that we are trying to hide something and there is more than what we are talking about. They desire full disclosure of the harmful error so that they are sure that all the information has been shared with them. They also want to know the implication to their health. What will happen now if we have removed my gallbladder, or if we have punctured my aorta, or if you have, whatever harm has happened. So what is the implication of this? And then who is responsible for it? It's very common. They will ask, who did this? Who is responsible for this? They really want to know the person. They want a face for that imaginary person who has done this happen. And then why did it happen? Like what exactly happened and why did it happen? And then how will you prevent the reoccurrence so that the others are not harmed because of this error? And then of course, apology. A lot of studies actually talk about these patients' expectations they want from us. So when it comes to disclosure gap, although almost all of us endorse that yes, we should disclose, studies also show that 90% of the doctors support the principle of disclosure. But honestly, only 30 to 40% of the doctors actually disclose, because we know there are a lot of concerns when it comes to disclosing. There's a lot of fear that comes to anybody's mind. So studies suggest almost 2/3 of the errors are not reported. Also, even if the disclosure happens, it never meets the patient's expectation. As we discussed earlier also, primarily the focus is on telling minimal that needs to be communicated. At the same time, because we have not had any proper training, so naturally, we are not very comfortable doing this. So I asked you, what is the hesitation? But why else do you think we do not disclose? Why else do you think we do not disclose? One is, of course, there is a fear of retribution, aggressive reaction, name, getting defamed or getting bad reputation. They're all there. Any other reason can you think of? Yeah, repercussions, absolutely. So there are some more here. For example, some of us are actually skeptical of the benefit of disclosing. If an error has happened and if we have taken a corrective action, what is the benefit of telling the patient? You will come across these arguments very often from people who have done a mistake, who have taken a corrective action, and patient is not in know of it. They'll say disclosure is unnecessary, because they feel you are unnecessarily going to distress the patient and the family by disclosing it. Also, at the same time, if the patient is unlikely to find out, all the more that they will not want to tell the patient party about what has happened in the patient care. Of course, the other concerns are, as we have mentioned earlier, that there's a fear of retribution, that there's a fear of legal action, financial judgment, or also they have to handle emotional reaction, aggressive reaction from the patient party side. So many of us are not very comfortable handling them, and there's a risk we also become aggressive in that situation. So we want to avoid that kind of a situation. Some of us also believe that disclosure is primarily a factual conversation, and there is no complex interpersonal conversation. So we put it in a very, very direct, straightforward words without addressing the emotions and the emotional impact on the patient party. There's some message in the chat box, is it? Of course, self-esteem issue, because you somewhere it's going to affect your self-confidence and self-esteem. I mean, a lot of people do not want to even accept that I have erred, because they feel, their self-confidence would go down and they just want to deny the responsibility. And then, of course, some of us believe that the outcome is not related to the action on the part of the person who is disclosing. So, like, for example, in this case that Mariam was, doing role play, I mean, you would get to hear, it's not me who has done it, it's my staff who is responsible for it. It's my nurse who brought the patient in. I was I was wearing gloves and my face was almost covered with mask, and I was busy seeing the report. I did not see the patient. So you will see them not taking the responsibility. Not only this, a lot of time, now I'm not sure if that happens, a lot of time surgeons would ask anesthetists to go out and talk about anything that has gone wrong in this surgery. Do you agree with me? A lot of times surgeons would not come out and they will ask the anesthetist to go out and talk to the family. Does that still happen? Or now anesthetists refuse, they say that's not my job, you go and talk to your patient. I think now they are more
as a team.
As a team. But earlier I've seen in lot of cases, surgeons would not come and see the patient and the family. They'll just send the anesthetist and go and say, they tell them that the condition has deteriorated and we are shifting the patient to the ICU, and that's all. And of course, lack of training is one of the reason why we
Surgeon.
are. Sorry.
I know of a surgeon.
Yes.
Even if the complication is occurred inside 40, outside he will come and everything is fine, the patient is fine, and we just keep him and he will go home. And then later on he will say, oh, okay, when I operated, everything was fine. Later on some complication occurred. So he absolves himself of all the responsibility by declaring that the surgery went off well.
Yeah, it's up. It's
And
post.
I have done my job.
It's post surgery. Something has
The-
happened. Oh my goodness. I agree. I agree. That's what I'm telling you. A lot of time people disown the responsibility. They don't take the responsibility and they put others in trouble. Absolutely. So if I may ask you, what do you think are the benefits of disclosure? What do you think are the, if
One
we
more thing, I
disclose?
would your question of self-esteem.
Yeah.
Whether you
I think
in
your
the
network is.
heart
Please
the
switch off your video. Dr. Praveen, please switch off your video. Your
and
audio.
that definitely is going to affect yourself.
Dr. Praveen, switch off your video
Sorry?
and switch
Audio
off.
is not correct.
No, no.
Okay, okay. What
If you switch off your
am I audible?
yeah, it's better now. Yes, please.
I have switched off my video. As of video, I will switch over to hotspot. Probably that will help.
Okay, let's try.
Okay. Now am I audible?
Yes,
Yes.
you.
Yeah. Right. The question the Suyog asked about self-esteem for not reporting. What I want to say is that whether you report or whether you confess your error or not, in the heart of heart, you know that you have made an error, and that will definitely affect your self-esteem. It is not the of acceptance or non-acceptance, because we know that we have made a mistake, and that is good enough to affect your self-esteem.
But I've seen lot of people, who even after making mistake, their confidence does not deter. They have so much of, self-righteous attitude that they believe, I mean, they are not responsible for what. I'm sure you must have also seen some, people, some professionals who would just assume I am right in my place. It is patient who probably did not respond to the treatment. I think we have all sorts of examples, but I agree. I mean, anybody who has conscience, they would actually feel responsible for what they have done, even if they don't admit openly. But in the heart of their heart, they know of the error they have made. Very true. That's very true. Yeah, yeah. So I was asking all of you, what do you think are the benefits of disclosure? If you disclosed, how do you think you will be benefited? I can see some message in the chat box. Trust. Yes, Mariam, I completely agree. If you come out honestly, it really wins patient's trust. We can convince the patient party well. Yeah, if you have been able to win their trust, then they will at least believe what you're saying is right. If you're honest and plan the corrective measures, patient will come back to you. Yes. Better patient doctor relationship. Absolutely. Definitely they'll trust and they will believe.
Ma'am, I want to say something that I think another Dr. Jayapraya said it. If it's a surgical complication, person will still accept. But if you have, it's your negligence. Instead of operating on the right side, I've operated on the left side. Or instead of this patient, I'm operating on other patient. It is really gross negligence. I don't know how we can, how any person can be justified. Because uska to life and death ka sawal ho gaya.
Absolutely. And this has happened. In one of the hospitals, this happened. They amputated on the wrong side.
No, ma'am, especially like we do cesarean section, and this is the most common surgery we do. But still, even at 3 a.m., that high alert mode is on, because this will be the new nurse. This will be the day something will go wrong. So even sometimes I will be again telling them display the mops, but they always, out of habit, sometimes even before you have counted, no, open it out again. You have to. So I think it's like driving. Till you are driving, if you're not alert, accident will happen. So that is really, you have to keep training. And where the mistakes happen, sometimes as you get more and more senior only, the mistakes also will become more complex. And you have to really keep learning, and you have to keep, but stay confident. Or if you think there is a training or something means, then get, support from your colleagues. And that's why nowadays group practice, where you are, at least with one more person, that really supports you
Really
when
good,
you're.
yeah. Absolutely. Yeah. Dr. Suyog, you wish to say something. Go ahead, please. Yeah.
Yeah, so the criminal negligence, it comes in some IPC with 2 years of imprisonment and without fine. And there's also another point that I wanted to make, that if there is a, say, for a team, and if there is a junior doctor and there is a unit head in that particular hospital, the junior doctor will not be held responsible. It's a unit head who is responsible for that negligence. Just to add.
Yeah, I think there is a recent change in the legal implications. Even I was reading this about civil and criminal error, and then I mean grievous injury and harm to the patient. I was reading the implications of that, and yeah, I agree. Now they've reduced from 5 years to 2 years, and also some financial punishment. I think both the things. Yeah. So, like mentioned by you, that if we disclose, I think one thing is that there will be trust and there will be communication. You still have a chance to talk to the family and explain them. Also, if you disclose, it ensures other patients' safety, because when you report error, when you talk about it, you would do RCA, you would do kappa, you would see that others are not harmed. Of course, ethical and legally also, we are supposed to be disclosing to the patient. If we are hiding, then it's again a crime. We are not informing, and then there will be quality improvement if you continue on regular basis. I mean, whatever errors you observe, if you address them, like we discussed in the beginning, that there has to be a department who works on the errors and do the RCA and tries to find ways to prevent those errors. I think definitely there will be quality improvement. Interesting.
Ma'am,
Yes.
I work in the quality only, and whenever there are real sentinel events, they get discussed at senior management, and nothing comes down to the quality team. And we come to know via, and we go and ask where is the incident form, and nothing has to be shown, nothing has to be disclosed. So nothing, they don't even want to reveal the whole fact to you.
Yeah, very true. I think the focus is majorly on, saving the hospital's image, and especially in the time where media is, looking for something that they can, uh, use to increase their TPR. So definitely every hospital is making sure that nothing serious comes out, and then they don't get
Or they give a discount, a big discount, or for the length of stay being increased, like that.
But then they don't want to come out in open and admit what has happened. Whereas interestingly, studies suggest that only 3% of the patients report or actually sue the hospital or the doctors. Most of the cases, whatever, I mean, how much ever unhappy they are, after a little bit of shouting and aggressive reaction and talking, you will see them calming down and then accepting what has happened. Whereas we fear that they will take legal course, but that's not easy, because even going to the court does not resolve the problem. Ultimately, it is the hospital with whom they have to sit and negotiate and make sure that the patient is looked after even after whatever harm has happened. Studies have also shown that patients, if they sue, they don't sue to actually, of course, compensation is one of the factors, but one of the reasons they want to sue the hospital is because of the poor communication with them. When they are not communicated and they feel that some information has been withheld, and the way they were treated, it did not have empathy, and I mean, their feelings were they had a feeling that they were not given a fair treatment and some information was withheld. So that's where they want to nail the hospital or the doctor and punish them, or use this as a way to get the information. talking about the disclosure part, I think that's a very interesting thing that I want to share with you. In a lot of hospitals, of course, not in India, I'm talking about in the Western world, a lot of hospitals are actually implementing full disclosure policy. So I'm sharing one experience of, University of Michigan, where they have tried to implement full disclosure policy in 2002. So they actually had three components in this policy. The first one was that if the patient was harmed, they said we will acknowledge it and we will compensate the patients, fairly and quickly as soon as possible. Second thing that they worked on was that if there is no error, but if the patient wants to, see it as an error and then they want to threaten the hospital and litigate, they will go and defend their case in the court. They will not just simply try to, cover up or let go of that opportunity to prove their, clarity. The third is, if there was any adverse event that did not lead to any major harm, but then definitely that needed to be addressed, they would actually study and make sure that how this can be avoided in future. So they implemented this policy in 2002. So once they did it, the complete study really showed a very drastic improvement on three parameters. One is their annual litigation cost came down to almost 1/3, which was around 3 million in 2001. In 2005, it came down to 1 million. Second is the average time to resolve the such cases of claims and lawsuit also almost came down to 50%, or less than 50% rather, over a period of 3 years. Even the number of claims and lawsuits almost came down to 50% or maybe 40% of that, where they were actually making sure that if the patient has been harmed by any of their hospital, care provider, the patient is fairly and quickly compensated rather than dragging the case to make sure that the patient ultimately forgets about it. So this is where I want to share a set of guidelines with all of you, which is actually based on the recommendation from the Canadian Patient Safety Institute and the UK's National Patient Safety Agency. Of course, we can have our own ways of doing it, but this will give us some way how we can go about doing it. Like in the previous session, we talked about breaking bad news. I think most important is, first of all, to prepare yourself. So make sure that you are ready for it. I mean, you really need to have all the information about the patient, what exactly happened, what did you try to, to correct the situation. There is no harm seeking assistance from your trusted colleagues, and we have been talking about it should always be done in a team rather than one person going and doing it. I'm so sorry. And then you have to really prepare yourself mentally for strong emotions, because I'm sure the patient party can act aggressive or may blame you or may charge you with all sorts of, allegations. So you really have to prepare yourself to hold the fort. When it comes to performing, I think it's important to remember that we have to start by stating that yes, an error has happened, because that's what they are waiting to hear. And if you try to avoid admitting them, they will make you first say this and then they will be ready to listen to you. But to start with, if you say, yes, there has been an error, and then you describe how exactly whole thing happened. But when you do it, it has to be done in a very, very non-technical manner, in a simple way, so that they understand what exactly happened. But if you talk about iota and then carbon dioxide and puncturing and all that, they would not understand and they'll rather be confused about what you have done actually. Then you can also talk about the nature of mistake and what are the consequences. For example, if it has dire consequences, you will have to make a mention that it was something very, very, I'm like, whatever has happened, it's very risky, or whatever you want to say. And then what corrective action you have taken. In between, you need to really, pause so that they get a chance to, first of all, understand what you have explained to them. As we talked in the last session also, it actually causes cognitive deficit, behavioral deficit, emotional deficit, because anybody and everybody would be shocked for a minute to listen to something like this. So you need to you have to go slow, you have to give them time to understand. And then also, in case if they have a question to ask. You have to give them a chance to ask questions and then answer their questions very, very honestly. Rather than you going with in one flow, telling them what exactly happened. If you allow them to ask questions, they'll have more comfort in understanding what you are saying. Of course, apology, we have talked a number of times. It's a way to actually communicate that yes, it has happened and you are sorry. So again, we fear that it will be kind of a legal liability on me, but that's what they expect. Legal liability will happen or not, that is later on. But a lot of time when you say sorry, it works and also helps them see that you are sorry for what has happened for them. Then if you shift your focus from here to the patient's welfare and let them see what you are going to do and what you have done to reverse the situation, you can shift your focus on that. Taking responsibility, using I statement that yes, I was there, I saw it myself, I attended myself. Don't blame on others or speculate that somebody must have done it, it is not me. And also do not accept fault unnecessarily. A lot of time we say I am responsible, I am responsible, so they may take that you are the one who has caused everything. If it has happened by you, then take the responsibility. Continue asking them what questions they have, what are their concerns, and that needs to be addressed, back and forth. Once you have discussed, once you have addressed their concern, it's time to make a follow-up plan. If you have moved the patient to the ICU, maybe you tell them that we have moved the patient to the ICU, this is what has been done, this is what is going to be done. At that same time, they may want to see the patient. They may want to come back to you after discussing with the family. They may want to have next update. So all that has to be kind of discussed with the family, that this is what is being done. And and if they say that we want to see the patient, if you can allow them to see the patient right away, you can allow. If you want to, you have some time before you can settle the patient, maybe telling them that we are trying to first work on the patient. The moment the patient is little settled, I'll give you an opportunity to go and see the patient. So, and also let them know how you are going to update them. If you tell them, somebody from my team will stay in touch with you, and every hourly or 2 hourly we will be updating you about the patient's condition. They will know that you are in touch with them. A lot of us sometimes switch off our phone, or we become inaccessible, or we refuse to give our phone number. I think that's a gesture that they would expect. Even if you give your phone number to them and tell them that in case if you have any question and if you want to talk to me, you feel comfortable, message me or call me, I will definitely. So in a way you are building communication with them. And if you switch off your phone, they would assume automatically that something you have done fishy and now you are acting inaccessible. Of course, after every interaction, it's very important to document whatever has happened. So this incident has to be documented, whatever happened and whatever actions you took, whatever was the rationale for the clinical decision you did. You started with lab colleague and then you opened the patient and then you operated. Whatever you did, whatever the rationale you saw in your clinical decision, that should be notified. Also whatever happened as a clinical outcome and what is the further plan of care, all that should be documented so that it comes out clearly that whatever you did was following the standard treatment protocol. Discussing whatever discussion you have with the patient and family, especially who was there when you discussed, their names and relationship to the patient, and also whatever questions they posed and the answers that you gave. If you can briefly write about that, that will create an evidence that you updated the family and you informed the family. After every incident, it's important to sit and reflect. Sit and try to see what exactly happened, how did you handle it, what could have been done differently. You could discuss with your colleagues, you could read a lot of material on how do you go about handling such situations. Even attending programs where you learn how to handle crisis situation is a good idea. I think programs like what we are doing here is nothing but we are trying to slowly become familiar with the ways of handling that situation. That's a short protocol of what you can do when you have to actually go and do the disclosure of medical error. Just to summarize this, I think the points that we have discussed, you prepare yourself for it. when you talk to the family, state them what happened in very simple and straightforward manner. Apology works. Take responsibility. Invite questions, because when you ask them to talk, you get to hear, are they agreeing, are they accepting, are they okay with it. That will give you an idea about their thought process. Discuss the follow-up plan so that they know that they have not been just left, but rather you are constantly in touch with the patient and also with them. The documentation, as I mentioned earlier, also is very important, and regular reflecting helps us become better. At the institutional level, I think it's very important that we integrate disclosure, patient safety, and risk management activities. We may have a wishful thinking that something like this should never happen, but you can't close your eyes to something that can definitely happen anytime with any one of us. So ultimately, institutions need to take initiative in training their staff, healthcare providers, where they learn how do you go about disclosing anything that has happened, providing them training, providing them opportunities to practice and learn. And then of course emotional support for people who make mistake. There's a concept of second victim. We have to actually implement them. The person who makes a mistake, or whoever ultimately is the one responsible for the mistake, even they are emotionally affected very badly, and they need to be provided that emotional support and safety. So creating a culture of patient safety and culture of employee safety is very, very important. That brings confidence in the system, and also confidence for the employees. And like we started this discussion, Dr. Praveen started this discussion, you need to create a culture where people report errors promptly without fear of repercussion. If you can create that just culture, that fair culture, that employee safety culture, I'm sure people will come out and talk about whatever error has happened. And then, of course, you need to have a performance improvement tool to track and enhance disclosure. So if somebody is doing the disclosure, there can be somebody who does the observation, and then we learn from that. Those, So this is in brief about disclosure of medical error. What questions you have about it?
Ma'am, like you said, even for the doctor, it's a big trauma.
Absolutely. Absolutely. It really causes a dent on anybody's, confidence and also mental health. And we really need to, work towards improving and also supporting. Just supporting is not enough, because when you support, then we don't learn from that mistakes and we don't try to improve ourselves. But if we do RC and if we do kappa, I think at least slowly there will be quality culture, and employee and patient safety will automatically be taken care of.
Can we make a different plan looking at the background of the party who is involved? Sometimes you can, from the beginning, you can feel that these are not people who are rationally thinking, logically thinking, and they are likely to become more physical and offensive. In that case, can we not disclose a few things?
Disclose what? Can we hide? That's what you're saying.
Yeah.
Should we not? I think this is what is in practice, honestly. But I would say right from the beginning, if you remember that session on handling aggressive patient party, to start with, I said we have to learn social triaging. If we learn to identify people who have unrealistic expectations, or who think money can buy everything, or who are connected with politicians and bureaucrats and they think they have access to everything, we need to identify such people. And it's always good to keep them in loop, especially if we know that there's a possibility of death or condition is not really good. It's better to promise less and deliver more in such cases, so that they better be prepared. But something like this, where we have heard, I think you can't escape the consequences, because a lot of time I have seen the hospital staff will go and disclose to the patient's family that this is what has happened in your patient's case. So when you try hiding this, I'm not sure how far you can really go on hiding and covering.
What I mean to say that I have seen situations like one of my colleagues, he was also a physician, and he was handling a very serious patient. The party was like that at least every time 20-25 people will always be around them and all aggressive, that sort of an low educated, not really listen to talk. And he offered them everything. I can refer him to the higher center, and I can give you another consultation. This for that they all refused. They said no, we don't want to anywhere treat him here. And then unfortunately what had to happen, the patient had to die. And then they suddenly the whole mob gathered and they become physical. So we could foresee this is going to happen. So in such cases, going and telling that I have made this mistake, will that be wise enough?
I know. That's what I'm saying. Theoretically, it might sound okay, but you have to take a call when you are in a situation. And I think we are very far from that where we can actually go out and talk openly like this. And we have seen mob attacks because there in the Western world, the people don't take law in their hands. They know that they will have dire consequences. In India, the mob knows that nobody will be able to catch hold of them. There are so many serious crimes happening in the country that nobody will come after the patient's family, looking for them and then, bringing them to the law. I don't think anybody fears that. Of course, the law has to be more stringent. Action has to be taken seriously. Even the hospitals who are attacked by mob, they should not, just be okay with it. It's okay if the patient party is apologizing and then let it be. There have to be some examples where the patient party receives the outcome of their misbehavior in terms of punishment or some compensation or even jail. That will deter people from taking law in their hands. But then every situation is different, and we have to evaluate which is the safest and best way to deal with that situation.
That's why it's very important. Everybody should be with their own IMA group.
Yeah.
And there is also indemnity PPLSS, which really their lawyers also come and help, and also indemnity insurance, because you can have a complication, and if things go out of hand, then but you cannot be working in fear of what will happen. But have the good
very important is taking timely action. If you can see there are a lot of people, sometimes we get aversive to the idea if there are 20, 30 people waiting outside. Why not build rapport with some of the immediate family members who you think are going to be there, and be little extra kind and good to them. Even that will help you build rapport and win their confidence, and they themselves can bridge the gap between you and others. But we also need to introspect. Are we building rapport with the patient party? Are we communicating? Are we transparent? Are we honest? Are we giving them the true picture? There are a lot of aspects to this situation. Yes, Dr. Siyog, I think you wish to say something. Please go ahead.
Yes, so the government of India, they have had this National Patient Safety Implementation Framework 2018 to 2025, and as per this, they had to develop a policy and guidelines for reporting of medical errors, be it for public or private hospitals, which was planned for 2018 or 19, but it hasn't come. But going forward, the government, I perceive that it's going to stay, and with the interim budget that has been passed with around or almost 4% increase of last year in healthcare, we are surely going to see. This is my personal opinion that we are definitely going to see some guidelines on regarding disclosure of medical errors, both public and private, and the code of conduct related to that. So just matter of time. Yeah.
Let's hope. Yeah. Any more questions or some views? Okay. So if no more questions, I think there are a couple of announcements that I wish to make before we have presentation by Nivedita. Nivedita, are you there? Yeah. Nivedita, and also Dr. Jayapriya.
Yeah.
Dr. Jayapriya, are you there?
No, I can't see her. She's
Yeah. Yeah. So this is regarding the requirements for the certificate. I think I had made it very clear. I mean, I kept repeating in the messages also that you need to attend at least 8 sessions, 8 or more than 8, to claim your certificate. And also you need to do presentation. Some of you have done it, some of you have not done the presentation. So you will have to now prepare a PPT, get it vetted by me, and then record your presentation like we do it on Zoom. Yeah, Jayapriya has come back. Yeah. So record your presentation and then post your presentation in the group. And if you have not attended 8 or more than 8 sessions, then you will have to attend sessions in the next batch, which I'll be announcing very soon. And because it's not that, I mean, I can give certificate for your, you have been enrolled for the program, but then what is the point of certificate if you haven't learned those sessions? There have been some candidates, even in this batch, I've informed them that they'll have to redo their, program to claim their certificate. And I hope everybody's okay with that. I think most of you have attended 8 and more than 8 sessions, those who are present here. I think most of you have done so. Those who have not worked on their presentation, I request you to now first share your PPT with me, discuss your PPT with me, and then record and send the PPT. That's my request to you. Second is, Dr. Praveen has shared that small video, 1 or 2 minutes video with me. Thank you, Dr. Praveen, for taking out time and recording that video. I mean, I know it's not easy to, first of all, sit and write and then, do the recording. But I request all of you to do the same. And it will be really nice if you could post on your LinkedIn, profile, and then tag me in that. I think we are all connected on LinkedIn. Are we connected on LinkedIn or no? Yeah. But with those whom I am not connected, I request all of you to connect on LinkedIn, because I keep posting some of the other work that I am doing on healthcare communication. So you will be in the know of it. And also, if you can post your video, it will be nice. Then it shows that you have done the program. Also, there's a way to talk about the program in endorsement. Can I request all of you to write few lines on your experience about attending the program, whatever it is. I'm not asking for any false praise or exaggerated praise, whatever has been your experience of attending the program, because that's how people get, motivated when they get to hear something from the participants that this has been your experience or learning. That's how we can make it. And also, I will be, I keep getting assignments from various parts of the country, and I want to involve all of you in some or the other way as trainer with me. So those who are willing to part with me, to become party to me in that program, I will be adding you to the group. You will get information about whatever program happen again, and I'll also share one link with you where you can write your details, so that I know that you are interested to participate with me as co-trainer with me. So wherever it happens, I can, if I'm in a particular state and if you are around, I will inform you beforehand, and then I can invite you to come and be my co-trainer. I hope that's okay. And then once I issue the certificate, I request you to talk about your certificate again on LinkedIn, because people should know that now you are a master trainer and they can avail your services. Because only when you will talk about what you are doing and what your achievements are, then they'll invite you for their program. So this is little bit from my side. I want to give a post program assessment. If you remember, you did one questionnaire before we started the program. I can do it here, or I can send in the group. I request all of you to complete that formality before you claim your certificate with me. So two links I will be sharing in the group. Complete that, and then I will issue your certificate. So those who have completed their requirement, They can create a message on the group, that list of people who have completed the requirement. You write your name, then others can keep adding their name to the list, and we can keep reposting so that we have an updated list. That list I can forward to my associate who would prepare the certificate for all of you. I hope that's okay. Any questions you have, anything you wish to, or maybe if you are comfortable, maybe if I ask you to give your feedback now, maybe few minutes, few seconds, few minutes, if you are comfortable. Yes, Dr. Siyog.
Yes, ma'am. Thank you so much for enlightening regarding the healthcare communication. It was that we knew it, but we didn't practice it. And thanks to this course, we were able to. I mean, I was personally was able to, understand those intricacies of healthcare communication. Thank you so much. I mean, I have learned a lot, and definitely I would research more and read more uh, to with that that base knowledge that you have given to us. Yeah, thank you so much, ma'am.
Thank you so much. Absolutely, it's a beginning. I think it's a journey that we all are moving on, and more you will practice it, more benefit you will find out of it, and I'm sure you will enjoy the fruits of your learning. Thank you so much. Thank you. Dr. Priyanka, I think, has raised her hand. Go ahead. I think after that, Dr. Praveen. Yes.
Yeah, thank you, ma'am. I, in fact, wanted to share one or two pictures of the slides just as an information on LinkedIn so that more people get to know, with your permission. Just nobody's face is there, just non-specific, like, some important points. So, because I think day in and day out, this is bread and butter. We are working, we are talking, but somehow during our, curriculum, the social skills are never developed, and we are always so focused on studies, and, things like that. But then, uh, of course, learning how to be a people's person, how to understand that body language. So I think it has helped improve my communication also, because it's a long time, 10 weeks, 3 months. So I can see that even though I've been working on that, try to be less, in a hurry, give time, let the patients talk. So I can feel that. Thank you so much.
Thank you, Dr. Priyanka, for your kind words. Thank you so much. Yes, Dr. Praveen. Go ahead.
Initially, when I learned about this program on the net, I was a little bit skeptical. Looking at my level of almost, I retired as a professor for 4 years and now no more teaching. Clinical practice also, I am almost weaning off. So I was not very sure whether it is going to be useful or not. But let me submit that I am really happy that I did attend. So I learned and I enjoyed it thoroughly. Not only learned, but it was thoroughly enjoyable. You are definitely a master trainer and you trained us all. But it was really pleasure to listen to our other participants also. They are also very learned. I am more of a listener. So I just wanted to listen what everything I was trying to imbibe, what exactly he's trying to communicate. So really, I'm very thankful to all of you and Madam you in particular for this particular program. I'm really very happy about it.
Thank you so much, Dr. Praveen. I think
Thank
the
you.
real learning was because of everybody's liberal, discussion about whatever we discussed. And you all came out with a lot of your experience and learning. And also, it's not easy to come out and speak about your failures and your, follies. But you were very liberal in sharing your mistakes or errors and discussing with all of us. And I think that enriches the program. That's the beauty of the whole program.
That's
so I
true.
played more of a role of a catalyst. The actual action was taken by all of you. Yeah.
Madam, we should not break the group, ma'am. That group in WhatsApp, it should
I
be
would.
like
No,
that
I don't.
way.
I don't. I don't dismantle the group. We are all very senior people.
Yeah,
So I don't
ma'am,
think
we can take help of each other communicating over there. If wherever I get stuck, I will communicate.
absolutely.
100%.
I never dismantle any group. I never dismantle any group because nobody post any unnecessary, stuff forward. So it's a completely safe place. You can always come back and talk to your group members. Thank you. Yes, Archana, I think you wish to say next. Go ahead.
So, as I have joined, I mean, as Dr. Praveen said, I was also a little skeptical because I am not a front runner or like I will not be handling any difficult cases or anything, speaking to so my profession is not anything like that. But yes, as I the purpose of joining here was to, I mean, communicate in a better way, whether it is to the healthcare person. Mainly, I joined because so that I can communicate words, better words to the healthcare professionals, not to the patient party. Patient party, I was already well versed. I have been doing, but I want to communicate well with the doctors with that confidence. Not only doctor, other healthcare professionals also. So that yes, definitely I have achieved, and I mean, I am more. I mean, after these 3 months, I'm more confident in putting up my words or putting up my thoughts into my day-to-day work. And now I am also able to allocate work to people, which I have never done.
So good. So good.
Everything I should take on me, like
Okay.
whatever it was.
So you have learned assertion in real
Yes.
sense.
I learned that
I
physical.
think that the personality type was very good. That owl, shark, turtle. So when you were stuck, I was stuck in a situation in my department. So I just went back to that. Okay, I was an owl, but now it's become, pani sir se upar ja raha hai. Now I'll become the shark. Chalo.
No,
I don't want
actually,
to become turtle, and that helped actually. So the whatever problem was, it just resolved. So I really, that was really amazing. I thought I'm an owl. Enough, owl. Go for it.
I used to be like most of the time, anything, any problem comes, Archana will solve. But now I thought, why I should? There are a lot of people who can do. I have another work which only I can do. So that's where I have changed. I started allocating work, and that is giving me a lot of peace of mind actually. Thank you so much. It was very, very nice interacting with and wide variety of people, I would say, wide variety of professionals I am interacting with. So I felt very nice with this group. Thank you.
Thank you for your kind words, Rachana. So thank you so much. I think you all have been wonderful audience. I thoroughly enjoyed my session with all of you. Every Thursday, I look forward to meeting you, interacting with you, and I know the session will go on, even if because you all have so much of knowledge, experience, expertise that there will be a lot of discussion, and I'm sure we'll come up with some new ideas. And today also, I think the discussion right in the beginning, Dr. Praveen took it to another level, and we started discussing something, but we had a deeper understanding of what exactly happens and what are the concerns. So I wish very best of luck to all of you. Take this program to another level. Use it to your best of your ability in your personal and professional life. And we will stay in touch definitely. We have two speakers today. We have Nivedita and then Jayapriya. So I think their presentation is not very long. It's just 5-7 minutes. Nivedita, are you ready with your presentation? So I'm just going to share the screen and
Yeah.
you can share. Yeah. And let's not forget to take a picture in the end for all of us.
But you do this. Now wait, you do this. Double click.
Ma'am,
Yes, Jayapriya.
yeah, see, while Nivedita shares her screen, for some reason my PPT is not opening. Is it possible to open your email and?
I will do that.
Yeah, thank you. Yeah.
Is it can you visualize that, ma'am? My screen?
Yes. Yeah.
Okay. Pedagogies to demonstrate communication gap. Let's do one activity. I told everyone to take paper, white paper. I mean, A4 size paper. Is it ready with everyone? Hello? Hello?
Everyone, please respond.
Yes.
Is it?
Just
Yes,
a
we
second.
have the paper.
Yeah, in case if you don't have it ready, please get one white A4 size paper.
Just a simple A4 size paper. Fold this paper into 2 halves.
So, Nivedita, should you be
Yeah.
showing the presentation?
Yeah, I will also show.
Simultaneously?
Yeah. Simultaneously, I am also showing that.
Okay.
No, আমি ভিডিওটা দেখতে পাচ্ছি না কেন বাবা? Just a minute, ma'am.
Sure.
Any amma ke dikkat achha.
We can't say
Click
something.
Yeah. Ma'am, just a minute. Huh? Some video I'm not able to see that. Madam, am I? Yeah. Yeah. That's it. Huh?
You're visible
Yeah.
to yourself.
Fold this into 2 halves. Fold the paper into 2 halves.
Priyanka has gone 3 steps ahead.
See,
You're
I
always
have
in a hurry, guide me.
Yeah.
see how I fold.
Uh-huh.
Let me see who all else. Priyanka madam. See, to overcome communication gap, audio visual plays an important role. Because I told and I did this. Priyanka madam has done something else.
She saw your picture and she did that.
मुझे पता था यही कुछ होने वाला था.
I am always visual learner. I can't hear. ADHD.
So there are plenty of activities to demonstrate communication gap when we do not communicate effectively or verbal communication only. And when we add audio visual, yeah.
Do you want to show your presentation simultaneously? Because we are not able to see.
You're not seeing
No,
my
you have stopped sharing. So please share your presentation.
In communication.
Yes.
See.
Yeah. Slideshow. Yeah.
Okay. See, plenties of exercise on communication gap and where we can use. When we want to demonstrate, we think our communication are powerful and very accurate. But this activity tells us that every individual sees situation in different ways. This can also be demonstrated as role of perception in causing communication gap. Suppose you are saying that this surgery has 90% success. Somebody who is casual will say 90% is very good rate. But for someone who is very particular about percentage will find 10% is very high. They might ask you, that means every 10 patient has risks or some complication. So these are different ways to show role of perception, then how communication gap happen. Failure may lead to irreversible damage to the patient. So advantage, there are many advantages are there. Still, I have mentioned few of them. It becomes easy to understand. All the sense are more. These activities are self-explanatory. Activity enhance memory, better organizations of information. Disadvantage, they are time consumable. Then they break the chain of thought because once, like Priyanka madam has seen and saw the visual and she did that way. Okay, but we stop thinking on that कि हाँ इसमें कुछ और निकल सकता है. So they break the chain of thought. Sometimes they are misunderstood. Do's is activity must be easy to follow. Activity should less time consumption. It should not be very long. Choose relevant and appropriate word. Choose effective audio visual. Don't make activity complicated. Don't be sure that activity neutral in nature. Don't be biased. That's all, ma'am.
Thank you. Can you stop sharing?
Yeah, ma'am. Let me stop sharing. Yeah, ma'am.
Okay. So if someone has a question to ask, please go ahead.
So again, I will ask the question as always.
Most welcome.
So in this, because the visual communication was the activity which was on the next slide, I can argue that You did not communicate properly. How do we overcome that kind of a situation? Because sometimes, like you were saying, right, we are telling something to patients, but they will listen only what they want to hear.
Yes, exactly.
So
Exactly. That's the communication gap. I myself made the communication gap.
so in hospitals, like any specific surgeries, now we have started, instead of even consent forms during surgery, sadly, it is just one paper which the nurse will get the sign. But if you go to UK, the day before the surgery, the patient is, or even much before the surgery is planned or they're admitted, each and every point is read. The patient can take it home, they can really read, and it's a detailed surgery specific consent form. So unless that changes, I think really we are still. I have seen myself. I have worked in corporate hospital in medical college, but the consent form is taken by the junior most first year postgraduate or MBBS, just the intern, who will have no idea what's happening. And then when there is a complication, then it's like I was never. So how do we change that? I mean, this is a mammoth exercise.
But if, as per NABH protocol, you have to take consent form before and explain it by the consultant.
Yes, that
as per
is
NABH protocol, and we need to follow now.
Some people who are doing it will keep doing it from the very beginning, but then that is where a lot of problems are most likely.
I think I agree with you. Maybe a couple of decades ago, the consent was primarily taken by nurses, if I remember. The doctor would just say, "Sister, sign le lo patient ki," and they will get this, consent. But things are changing at the same time. How much of actual explanation happens? That's still a question to be asked, because not everybody goes to the extent of explaining the complications or the risks or the disadvantages. But yes, some amount of explanation, at least about the procedure or what is going to be done,
Especially
is
in
not.
or even the risk of death also. I used to work with the right risk of death. And I really learned, you have to tell patients.
Nowadays we take high risk consent form also.
Yes, we have the form.
It may be
It is not everywhere.
It's the same. Has the patient actually read the whole thing and understood?
No, we that's why it is, first of all, we made it bilingual. You can see, as per NABH, it should be bilingual. Then you need to explain at least as a layman type. You cannot say, jitne scientific way mein likha rehta hai, but you cannot.
Consent form. I will share a sample consent form which is used in the NHS about very common, rare, very rare incidents, how it is explained. So unless we bring about changes, just writing risk of hemorrhage, risk of this risk, we never explain the percentages in detail. We never do. I will just share a sample form and you will see how much, of course, it is changing. Even the Foxy, our Gynae Society, where many procedure specific consent forms are coming out, but there is a long way. Like unless we have a system, it's I don't know when, because it's just trying to catch the tail and we are just going round and round.
Dr. Priyanka, if the patients actually read the entire consent form, forget about surgery, central line or any catheterization, now they have consent form and buttons for everything. If they actually read the entire thing, they will not consent. Majority will not consent.
No problem. I would really be happy if consent, even risk of death, this. If you're ready, come and do the surgery. Rather than just quickly tell them, and that's where the problem happens. If the patient trusts you, they know, they would have also researched. So that's
your point is well understood, Dr. Priyanka, with regards to the geographical locations. I think we're comparing the population in NHS. I myself come from Australia, and where we have a lot of geographical differences in the basic type of patients that to come. Even in Bombay, even in this elite institute where I am in, I still do have people from a high level family, well educated, still completely unaware of anything. So I think it's more got to do with the your point is well taken that the surgeons and we as doctors do not stratify our risks and put it forward to them in a stratified manner. That's because there is no culture that needs to be a paradigm shift. That's going to happen only when it's taught at the level of an MBBS. Once the MBBS doctor has been told that these are the risk factors of oxygen being used as a drug, we don't even understand that oxygen is being used as a drug. So a basic thing from there, if you understand the importance of that, then they will be able to understand the importance of, a 90% success rate in a surgery where the 10% is honestly too high. And if this was a situation in NHS or in Australia, I'm sure a relative would ask. I've had relatives who come up and ask, how many times in your career you might have put in 1,000 central lines? How many times have you had a pneumothorax and which has led to a fatality? And I've said, well, it's happened none. He's like, okay, I'm fine. Then I want you to do it. I don't want him to do it. I said, that's not the way it works. Yes, as one of you all pointed out, this is a 2D procedure and it's not a 3D procedure. This is a paradigm shift. And I think this point is appropriate what you're putting forward, that yes, we are not optimizing and stratifying our consent forms. That paradigm shift needs to come from the government. If it doesn't, we will never improve.
No, that's what I'm trying to say is in gynae, Foxy, our body has now tried to circulate procedure specific consent forms where at least it's not just a general consent form. There is some, of course, I'm not comparing any two different countries, but then that uniformity is taking, it is going to take time, but unless that happens, and then always, the sign line, what the patient has signed on. So I do agree, but we need to change something somewhere.
Absolutely.
The important thing in India is evidence-based medicine is down and expert-based medicine is very high.
Ma'am, in Ophthal,
Now,
even now today,
cashless and all, now things are getting streamlined. Yes, I hope that.
hello.
Yeah.
In ophthalmology,
Yes,
now we
exactly.
have 60 plus consents, which is procedure specific. The consents are in place because I myself have prepared so many in bilingual. But at the end of the day, the end user, the consultant doesn't actually explain and sign in front of the patient. It is always done by an intern or by a BHMS or a BAMS doctor. And that's the harsh reality of today. Despite all NABH, and I myself doing so many NABH audits, this is there.
True. I think we are going slightly off the track. The topic was the pedagogy that Nivedita had talked about, but then it's okay. I think it was all related. So can we have the next presentation by Jayapriya?
Yes, ma'am. Ma'am, if you can kindly share the screen.
Oh, yes,
Meanwhile,
I
I
have
have
to.
sent a link in the WhatsApp group. If I can request the participants to go into the link, it is basically a puzzle. It is a
So
jigsaw
do you want to
puzzle,
start
a
sharing
very
or
easy one. Yeah, it's a very easy one. 3x2 jigsaw puzzle. Can you quickly go? It will be comfortable to do it from your iPad or laptop rather than your phone. It may be a little clumsy if it's in your phone. So I'm
But
giving
then
you
no need to take it to their laptop, no? It would be possible for anyone to now take it to the laptop.
No, they can do it on their phone.
So what they can do, if you could put the link in the chat
It's
box.
possible on the phone, madam.
Okay, then you can, yeah. So you finished, Dr. Mehul. You've completed the puzzle.
Just
Yeah.
ending.
Yeah. It'll take a few seconds only. So who has finished it first, then, you can raise your hand. Good, good. So, yeah, anybody else? Dr. Indu is done. So I'm waiting for the others. Meanwhile, Dr. Indu, can you share the PPT?
Sure.
Yeah. So my topic for the day is how to use puzzles as a pedagogy to introduce a topic. So that's the picture that is a puzzle that I've given to you all. And can someone comment about this cartoon? Can one of you comment?
It's a male and hysterectomy is written on that file.
Yeah, yeah. So yeah,
Yeah.
basically wrong surgery. Oh, that's what we're discussing all the while today. So yeah, so puzzles can be a fun and interactive way to introduce a new topic. And the jigsaw puzzles are the oldest pastime where, a lot of pieces have to be combined to rearrange and fit and create a picture. This is a representative picture of the very first jigsaw puzzle that was made in London by a map maker. So basically, he stuck the map on a wooden board and he cut it into different countries, European map, the European countries, and then he made school children fit it together. And that's how it originated, the jigsaw puzzle. So there are different types of puzzles. The jigsaw puzzle is one. A crossword that we usually do in Hindu newspaper. I used to do it as a child. I look forward to crossword, Sudoku, brain teasers, even word search puzzles are different kinds of puzzles. So puzzle can be used as an icebreaker, when you're opening a topic to get the audience relax and, loosen up and then get interactive. A puzzle can be used to set a context for a topic. For example, the one you did now, it is a cartoon saying, wrong surgery. So when you're discussing medical errors, if we start the session with a puzzle like this, and people start discussing about it, and of course, to get the attention of the audience during a boring session. So how can puzzles be used? So the first example that I've given you now, what you've done is to describe the topic that you want to introduce. And when the students solve the puzzle, they get an idea of what the topic is, and they start thinking and talking about the topic. Another way to use a puzzle is to use a crossword puzzle. Ma'am, can you shift the slide? Yeah. So the crossword puzzle, whereas you can give clues related to a topic, some words, or as you can see in this picture, this is a word search puzzle. So in healthcare communication, you can make them search for some words that you've already given. So they, for example, here, assertion, clarity, courtesy, rapport, compassion. These are all pointers towards the topic that you're going to introduce, and the students will become familiar with the vocabulary of the session. So what are the do's and don'ts when you're using puzzles? So the puzzle should be subjective, it should be contextual, it should generate curiosity among the audience, it should be neutral and non-communal. For example, I've shared a picture, a cartoon. So it can't hurt people's sentiments and feelings. The don'ts is it can't be too complicated. So you give a jigsaw puzzle, 100-piece puzzle, it's too complicated to solve and they lose interest. It should not cause unnecessary conflict. It shouldn't be too long, and it should not target any religion or caste. What are the advantages and disadvantages of using a puzzle to introduce a topic? Advantage is a very quick way. They are very interesting, and it can engage audiences across age groups, from a child to an adult to a senior citizen. It can engage everybody. Complex puzzles can make the audience disinterested, as I told earlier, and it can lead to judgment among the people, among the students. So I'm coming to the end of my talk. So can you spot the 10 differences in this picture? I know it's too small, could have been a little larger.
Yeah, one with stethoscope, right side, yeah. One with stethoscope, but there is no stethoscope is there. Then one point is that, then
Apple has one, no leaf.
Yeah,
Quilt
color of the bottle.
There's
Yes.
pattern of the quilt.
Yeah.
Leaf on the apple.
Yeah.
the bottle.
Bottle color.
Yes.
Cheeks of the teddy bears.
H on the neck of the
7.
patient bear.
Thermometer.
Yeah.
Yeah. I think 9. One more?
Yeah, pattern on the neck, she said, Archana, I think. So the
Bandage of the patient neck.
Is it the bandage or thermometer?
Thermometer.
It's looking like something.
I know, it's
each
too
of
small
the
to
teddy
see.
bear
Did
has
they-
something.
On
Did they say
the
the
cheek, there is
color of
blush
the
on the cheek.
Yeah.
color on the bottle at the back?
Yeah.
The one is orange and the other one is
Cheeks of the
blue.
doctor.
Yeah.
So you can also use spot the differences to introduce as a puzzle when we're making a presentation, and then it makes it very interesting. I've kind of made it very concise so that we don't waste time on the last day. So I end my talk there. So I thought I should share one more feedback, Dr. Indu. 2 days ago, I operated on a pregnant lady. It was a semi-emergency. And I was sitting in my OPD, and then they were first the lady and the father had come. The next visit, the lady, the husband, and the mother-in-law had come. The moment I said surgery, they called and somebody else entered. It was the husband's relative. Then again, they called and the patient's mother and sister entered. So I had a crowd in the OPD, and I had to repeat what I said again and again. And every time they were going on bombarding me with questions. A normal day, I would have gotten really defensive and intimidated. So the questions were, you use titanium clips. So when will you remove those clips from inside the body? What will happen to the baby? Now she's 16 weeks pregnant. So will this surgery cause pain during labor? Will this surgery cause cesarean section later? Too many technical questions, not only this, and this is in front of this lady who's 16 weeks pregnant. Completely, they're treating her like an object, and they're going on asking such complicated questions in front of her. And I wanted to put an end to it, but I've been very patient. My assistant is indicating to me that it's 1 hour, what are you doing? And we have a patient waiting. Then finally, I thought, okay, I said, see, I'm here with you in this. I thought of Dr. Indu. I said, see, I'm here with you. I know it's not easy. I know it's difficult. I said, you should trust me. And I said, I'm here with you. I will take you through this in a safe manner. And the one thing that perturbed the family was, is it 100% guarantee that, nothing will happen to the baby? I said, the safest time to operate during pregnancy is the mid-trimester. So I said, I can't say it's zero risk. There is risk, but it's lowest now, and we have to accept it. And if we miss the bus now, and there's a complication later in the last trimester, and then, it ends in other complications, preterm labor and things like that. So the final, I could end the conversation by saying that, see, I am with you. I will take care of you, And the moment I said that, they all cooled down. So that's a shift in my, normally they go on bombarding, I become very defensive. And then, I would say something to cut short the conversation, or, I might say something, I'll become passive, passive aggressive. So this time I could come over the crisis because of your teachings, Dr. Indu. And, there's more to, because when I entered this course, I thought I know about communication. I'm a good communicator. Wherever I work, people appreciated me for the communication. So I thought I know everything. What is the big deal? What is she going to talk about and things like that? But I so much to learn. Actually, so much to learn about my own self, introspect. So thanks so much. Thanks a lot.
Thank you so much, Dr. Jaipriya, for
So much
such a
to
wonderful.
unlearn also, I would say. So much to unlearn or relearn, I would say.
That's true. I think for all of us, that's true, that we have to unlearn and we have to relearn something new. So this brings us to the end of the session and also the program, but we will stay in touch. I have posted 2 links in the group. I request all of you to complete both the links by tomorrow. One is for the post-program assessment, and second is for the details, so that we can stay in touch in case if I have some programs in nearby vicinity where you are practicing or working, so that we can engage together as trainer and co-trainer with me. Thank you so much. Oh, I want you to take a picture for all of us. Can I request Dr. Siyog to come in? Dr. Siyog, are you there? Can I
Yes,
request you to
ma'am,
have
I'm
your...
there.
Can I request you to
Yes,
have
yes,
your...
I'm just turning it on. There is
Sure.
there is some network issues, but yes, I will do it.
I understand.
Here I am.
So we'll take I'll take a screenshot and I'll share in the group. Mariam, ऊपर देखो. Mariam, मुस्कुराओ भाई देख के. Thank you everyone. Good night. Bye-bye.
Thank you, everyone.
Thank you, ma'am.
Thank you, madam. Thank you, everybody.
Thank you,
Thank
ma'am.
you
Thank
everyone.
you.
प्रवीण सर आई हैव गिवन यू
now.
प्रवीण सर
Sorry,
मैंने
please?
आपसे शेयर कर दिए जो आपको चाहिए था ना इन्फेक्शन कंट्रोल हाँ मैंने आपको दे दिए सर
Thursdays are going to be free now.
मैडम
Enjoy your
फिर
schedule.
और एक कोर्स स्टार्ट कर दीजिएगा अगेन वी विल कम
I'm thinking of starting a leadership development program.
हाँ मैडम करो ना वी विल कम
Because that's one training we all require. How do you go about handling your own team and then, doing well? So I have that idea. I've done that program for Reliance with Dr. Mehul. If you remember Dr. Mehul, I think some of the topics we covered there. So we can definitely plan something like this.
Madam, I need
Sure.
very much. Being an operation manager, I need very much.
ठीक है, done.
Maybe.
Okay.
Bye, everyone.